Welcome to today's deep dive. We're tackling a pretty heavy topic today, but it is an incredibly vital one. We're going to be looking at the science, the psychology, and the clinical approaches behind suicide prevention.
Yeah. It is a weighty subject,
Hmm.
but the mission of our deep dive today is it's entirely focused on empowerment.
Right.
We want to equip you with a thorough, compassionate, and really scientifically grounded understanding of what is, well, what's truly a major public health crisis.
It really is. And our source material for this exploration is a highly detailed medical chapter. It's called Suicide Prevention and Psychiatric Nursing Care.
And by the end of this conversation, you're going to have a shortcut to being well informed on how professionals actually assess risk, some of the surprising psychological theories behind why people take action, and how everyday conversations can literally save lives.
Okay, let's unpack this by just looking at the sheer scale of the issue. Because if you follow public health at all, you know suicide is a crisis. But what really jumped out in this clinical research is the trajectory.
The trajectory is deeply concerning.
Right. According to the 2018 data, we are looking at more than 48,000 deaths in the United States alone. But the most alarming part
Is the increase.
yes, from 1999 to 2018, there was a 35% increase in the total suicide rate.
We aren't just dealing with a baseline issue here. We're dealing with an escalating epidemic.
Exactly. And to put that into a day-to-day perspective, a suicide occurs every 11 minutes in the U.S.
Every 11 minutes.
Yeah, that is 132 Americans dying every single day.
Those numbers absolutely demand our attention. And when you dive into the clinical analysis, you see that the primary barrier to addressing this crisis isn't just, a lack of medical resources.
It's the social aspect.
Exactly. It's society's unwillingness to talk openly about it. The stigma is just massive.
It's huge.
People with strong suicidal thoughts often do not seek treatment simply because they are terrified of being judged or marginalized or completely misunderstood by the people closest to them.
And one of the biggest hurdles creating that stigma is just the sheer amount of misinformation out there. Popular media, television portrayals, they often just make it worse.
Oh, absolutely.
So the first thing we really need to do is dismantle the myths that keep people silent, because clearing away that fiction is step one.
Let's do it.
For instance, there is this pervasive idea that suicide only affects individuals with a diagnosed mental health condition. Like if you don't have a diagnosis, you're not at risk.
Right, and that is a major misconception. The reality is that while mental illness is absolutely an important risk factor, not all people who die by suicide have a mental illness.
Interesting.
Yeah. And conversely, many individuals who do live with severe mental illness never experience suicidal thoughts.
So tying them together as this absolute rule is a mistake.
A huge mistake. It prevents us from seeing the crisis in people who might be suffering from acute situational distress, but don't have a psychiatric diagnosis.
Okay, then there is the myth that it happens completely out of the blue. People often think, they couldn't have stopped it because there were absolutely no warnings.
That's one of the most dangerous myths out there, because it leaves surviving friends and family feeling entirely helpless. But in reality, sudden, entirely unprompted suicides are exceedingly rare.
They usually show signs first.
Almost always. Behavioral or verbal warning signs precede almost every attempt. It is rarely out of the blue if you know what dynamic shifts to look for, which we will get into a bit later.
Good to know. Another thing people often assume is that if someone becomes suicidal, they will just stay suicidal forever. They view it as a permanent, unchangeable state of being.
Which can make the situation feel incredibly hopeless for everyone involved. But active suicidal ideation is very often short-term.
Really?
Yes, it's short-term and highly situation-specific. Yes, the thoughts can return during future crises, but they are not a permanent personality trait. People can and do recover and live long, healthy lives after a period of intense suicidal ideation.
Wow. And that brings us to what is probably the biggest myth keeping people from actually helping their loved ones. The fear that talking about suicide will plant the idea in someone's head or encourage them to do it.
What's fascinating here is that the exact opposite is true. Treating suicide as a taboo subject is what actually endangers lives.
Because it isolates them.
Exactly. It
Yeah.
isolates the most vulnerable people. When you avoid the topic, you leave the person alone with their darkest thoughts.
Huh.
Talking about it directly, asking the hard questions, it actually reduces the stigma.
It brings it out of the
It
shadows.
provides a massive sense of relief. It allows the individual to rethink their options, share their story, and actually seek help because someone finally acknowledged their pain.
It is literally a life-saving intervention just to bring it into the light.
Absolutely.
So now that we have cleared away those societal misconceptions, let's look at the clinical language. Understanding the vocabulary helps us really understand the reality of the crisis.
Right. Words matter here.
They do. There is a very specific difference in the text between suicidality and a suicide attempt.
Let's break that down.
So suicidality is an umbrella term. It covers all the related behaviors and thoughts, thinking about it, planning it, visualizing it. But a suicide attempt is defined specifically as a non-fatal, self-inflicted destructive act with explicit or implicit intent to die.
And then there's a term that might be new to you, parasuicide.
Right?
This is often referred to in older literature as a suicidal gesture. This is where the conscious aim is not actually death.
Like what?
For example, taking a sublethal dose of a drug or inflicting a non-lethal injury. The motivation here varies wildly and is deeply complex.
So it's not a failed attempt, it's something different.
Yes, sometimes the person just desperately wants to essentially feel nothing for a while to escape overwhelming emotional pain. Or they desperately need to send a message about their emotional state because they feel completely unheard.
But people often dismiss that as just seeking attention.
Right, they do, and it's terribly damaging. The clinical consensus is very clear on this. Parasuicide behavior is never just seeking attention in a dismissive sense. It is never normal, and it must always be taken seriously as a profound sign of distress.
The final key term in understanding risk is lethality. This is the probability that a person will successfully complete suicide based on the seriousness of their intent and how likely their planned method is to succeed.
And lethality is a massive factor when we look at who is actually at risk. It is devastating to see how demographic disparities play out.
Yeah, because we know suicide touches every community, but the ways it impacts different groups are vastly different.
Let's dive into that demographic data because it reveals a lot about how society functions. There is a profound gender paradox here.
This stood out to me.
Women are 3 times more likely to attempt suicide than men. However, men have a completion rate nearly 4 times higher than women.
Wait, so women are attempting at 3 times the rate, but men are completing at 4 times the rate. That is a massive discrepancy. What exactly is driving that gap?
It comes almost entirely down to the lethality of means.
Ah.
Men are much more likely to choose highly lethal, immediate methods. In fact, 56% of male suicide deaths involve firearms.
Wow. Over half.
Yeah. And when a firearm is used, the chance of survival and subsequent intervention drops to near zero. Because of this, white males specifically account for roughly 70% of all completed suicides.
And geography plays a huge role in that lethality, too. The research notes that the highest rates are in the mountain regions of the U.S. and in deeply rural areas. And that gap between rural and urban men is actually widening. It's heavily tied to higher rates of gun ownership and social isolation in those rural communities.
Geography matters immensely, and so does age. You might assume teenagers are the highest risk group given all the media focus on adolescent mental health.
That's what I would have thought.
But suicide rates actually peak during middle age.
Really?
Yes. Then there is a second, very distinct peak in adults age 75 and older.
What's driving that older peak?
Chronic physical illness, loss of a spouse, and intense social isolation become major precipitants.
That makes a tragic sort of sense.
But there's a really interesting cultural variation, too. In Asian or Pacific Islander populations, the suicide rates uniquely peak much later in life, specifically in those over the age of 85.
Wow. We also have to highlight vulnerable populations because the disparities here are just heartbreaking. LGBTQI youth are nearly 5 times more likely to attempt suicide compared to their heterosexual peers.
5 times.
Yeah. And for transgender adults, a national study found a staggering 40% attempt rate, with 92% of those individuals making the attempt before the age of 25.
The clinical data clearly links this to gender-based victimization, systemic discrimination, bullying, and profound rejection by family and communities.
It's a clear example of how societal environment directly impacts mortality.
Another highly vulnerable group is our veterans. They die by suicide at 1.5 times the rate of non-veterans.
Which comes out to an estimated 18 veterans dying every single day.
And that is often linked to PTSD, untreated combat exposure, and the intense stressors of transitioning back to civilian life without the built-in camaraderie of the military.
And we can't ignore the impact of chronic society-wide stress. We saw this incredibly clearly during the pandemic. In June 2020, a national survey found that nearly 11% of adults reported having seriously considered suicide in the previous month.
That pandemic data perfectly illustrates how distress, sudden isolation, fear of the unknown, and massive economic hardship act as powerful catalysts.
Yeah.
Social isolation is consistently identified as a primary risk factor across every single demographic board.
Okay, so we know who is at risk, and we understand the environmental pressures. Let's transition from the who to the why.
The underlying mechanisms.
Right. How does someone actually cross that terrifying threshold from having these dark thoughts to taking action?
It's a complex web.
It really is. If we look under the hood at the biology of this, researchers have found some incredible physical links. Biologically, those who complete suicide often have extremely low levels of the neurotransmitter serotonin.
Yes, the chemical component is real.
And there's a strong genetic component, too. Twin studies show a 50% concordance for completed suicide, meaning if one identical twin dies by suicide, the genetic and biological vulnerability for the other is incredibly high.
Psychologically, clinicians often look at Aaron Beck's famous cognitive triad of depression.
Okay, what is that?
This includes three overwhelming persistent feelings: hopelessness, helplessness, and worthlessness.
That's a heavy combination.
It is. And hopelessness is the real driver here. It isn't just feeling sad about today. It is the pervasive, unshakable belief that undesirable events will continue to happen forever, and things will literally never improve.
So they just see no way out.
The future is viewed as a black wall. That specific brand of hopelessness is heavily linked to severe suicide ideation.
Here's where it gets really interesting, though. The data shows that in 2019, 4.8% of adults had serious thoughts of suicide.
Millions of people.
Exactly. But the vast majority of people who think about suicide do not act on it. So what bridges that gap? Why do some people cross that line while others don't?
That is the most critical question in modern suicidology. And it's answered beautifully by Thomas Joiner's interpersonal psychological theory of suicidal behavior, or IPTS.
IPTS.
Yes. Joiner proposes that for someone to be at high risk for actually dying by suicide, three very specific interacting factors must converge at the exact same time.
Let's break those down because this framework is a huge light bulb moment.
First is thwarted belongingness. This isn't just a fleeting feeling of loneliness. It is a deep, agonizing sense of alienation, where the fundamental biological human need to belong to a pack or a community is just not being met.
A biological need, that's powerful.
Second is perceived burdensomeness. This is the tragic, distorted misperception that the individual is a literal burden to others.
So they think people would be better off without them.
Exactly. Their depression lies to them and convinces them that their family, their friends, or society would tangibly be better off if they were gone.
So if someone feels like they are completely alienated and they genuinely believe they are a burden, that creates the desire for suicide.
Yes, the desire.
But having the desire still doesn't explain the action.
Exactly. That brings us to the third and most crucial factor: acquired capability.
Okay, what is that?
Human beings are biologically wired to survive. To overcome that primal survival instinct requires something extraordinary. Think of acquired capability like building a physical callus, but on your psyche.
A callus on the mind.
Right. Through repeated exposure to trauma, chronic physical pain, previous self-harm, or even exposure to violence through their profession.
Like doctors or soldiers.
Exactly. A person slowly builds a tragic tolerance to pain and a fearlessness of death. The act of suicide is incredibly difficult to carry out. You have to acquire the capability to do it over time.
So it's only when all three of those converge, the thwarted belongingness, the perceived burdensomeness, and the acquired capability to overcome the fear of death, that the risk goes from ideation to extreme imminent danger.
If we connect this to the bigger picture, you can see how other emerging clinical frameworks like the three-step theory echo this exact sentiment.
How so?
The three-step theory suggests that emotional pain and hopelessness cause the thoughts. Those thoughts get stronger and more dangerous when the pain exceeds the person's connectedness to others.
And the action.
The actual attempt, the final step, only happens when the person has developed the physical and mental capacity to carry it out.
It's a fascinating and sobering way to understand the mechanics of it. We also see social theories playing into this, dating way back to Emil Durkheim in the late
He
1800s.
was a pioneer in this.
Yeah, he linked suicide directly to social conditions and lack of societal integration. And today we see that manifest in the very real phenomenon of social contagion, or cluster suicides.
Yes, contagion is when social exposure to suicide increases a person's own risk, especially among adolescents whose brains are still developing.
It's a copycat effect.
It operates through psychological modeling. If a peer or even an idolized celebrity dies by suicide, it can trigger copycat behaviors in vulnerable people who are already struggling.
The source material is really clear on this too. It explicitly notes that the amount and prominence of media coverage of a celebrity suicide is directly proportional to the number of copycat acts in the weeks following.
Which makes how we talk about it and how professionals intervene so incredibly important.
Let's move to the front lines of intervention then. How do psychiatric nurses and professionals actually help someone in crisis?
First, they have to recognize the signs. Professionals use a mnemonic called "is path warm."
Is path warm? What does that cover?
We don't need to memorize the whole thing, but for context, it stands for ideation, substance abuse, purposelessness, anxiety, trapped, hopelessness, withdrawal, anger, recklessness, and mood change.
That's a lot to look for.
The key here isn't to use it as a static checklist. It is a tool for spotting dynamic shifts.
So changes in behavior.
Right. Is the person suddenly acting remarkably reckless? Is there an unexplained spike in substance abuse or sudden uncharacteristic anger? It's about spotting a sudden escalation in behavior rather than just observing chronic sadness.
But spotting the signs is only half the battle. The clinical standards emphasize the sheer power of asking directly.
This is critical.
There is a case study about a patient named Caroline in the text that illustrates this perfectly. Imagine the scene. Caroline comes into a clinic just to see a nurse practitioner for a common cold.
Should be a simple visit.
It'd be a 5-minute visit. But the nurse notices she is unusually sad, physically downcast, and not making eye contact. As they talk, the emotional dam breaks.
Yeah.
Caroline starts crying, revealing a history of severe childhood abuse, a father who died by suicide, and a highly critical mother who lives with her. She is drowning.
This is where clinical training makes all the difference. In an ineffective approach, a professional might essentially brush off the emotional weight.
Because it's uncomfortable.
Because it's uncomfortable or because they are pressed for time. They might offer the cold medicine, suggest she find a therapist in a dismissive way, and fail to validate Caroline's immense pain.
And what happens then?
If that happens, Caroline immediately gets defensive. She asks to just get her medicine and leave. The door slams completely shut, and a critical opportunity is lost.
But in the effective approach, the nurse leans in. They ignore the clock for a moment. They validate that things are piling up and that her feelings make sense.
May make her feel seen.
Yes, they ask open-ended questions. And most importantly, when Caroline hints at wanting to escape or doing what her father did, the nurse asks directly, without flinching, without apologizing for the question.
So you think you might take your life, like your dad did.
Exactly. And then do you think about suicide every day?
That directness is absolutely everything. As we mentioned earlier with the myths, many well-meaning people worry that asking about suicide will plant the idea.
But it doesn't.
The clinical reality is that the patient often already has these thoughts. When a professional or a friend recognizes how serious their pain is and asks directly, the patient feels immense relief.
They don't have to carry it alone anymore.
They finally feel a sense of social connection in their darkest moment. You never promised to keep suicidal thoughts a secret, but you must ask the question openly and plainly.
And it's interesting because the clinical practices for what happens after you ask are actually evolving right now.
They are.
For years, the standard in psychiatric nursing was to make a patient sign a no-suicide contract, literally a piece of paper where they promised they wouldn't kill themselves for a certain period.
But current research reveals these aren't actually evidence-based.
Right. Careful evaluation showed that just making someone promise not to die doesn't actually prevent suicidal behavior.
It just protects the hospital from liability.
Exactly. Today, the recommended standard is a commitment to treatment statement, or a CTS.
Which is much more collaborative.
Right. Instead of restricting their rights or forcing an empty promise, the CTS asks the patient to commit to trying new approaches, engaging in their own recovery, and communicating openly and honestly about their thoughts.
Including the suicidal ones.
Yes. It is about building a therapeutic partnership, not just forcing compliance.
Even when things escalate and hospitalization is required, The reality of inpatient care is heavily nuanced. The guidelines clarify that just putting someone in a hospital room and observing them isn't therapeutic on its own.
It's just a holding pattern.
Exactly. Mere observation just ensures physical safety, keeps them breathing, but it only becomes a therapeutic intervention when a nurse actively interacts with the patient during that observation.
So they have to engage.
The goal of inpatient care is to help the withdrawn, isolated patient reestablish personal control and find alternative, healthy ways to manage their extreme emotional distress before they are discharged.
Because the stakes couldn't be higher, not just for the patient, but for everyone around them. The clinical literature points out the devastating ripple effect of a lost life.
It's profound.
One suicide leaves at least 6 survivors, immediate family and close friends who are deeply, permanently impacted. They are left struggling with immense trauma, complicated grief, anxiety, guilt, and profound shame.
And that familial disruption can literally last for generations.
Which is why post-suicide survivor peer groups and dedicated interventions for the family are so necessary.
The trauma doesn't end with the loss of life. It radiates outward into the community. Treating the survivors is a crucial part of preventing future crises.
So what does this all mean for you listening right now? We've gone through textbook definitions, stark demographic realities, and deep psychological frameworks like perceived burdensomeness and acquired capability.
We've covered a lot of ground.
The incredible value here is that you are now equipped to look out for your friends, your family, and yourself in a much more profound way. You know that asking directly isn't dangerous. It's a necessary life-saving tool.
You also know the vital importance of protective factors. The research highlights things like effective clinical care, strong problem-solving skills, and cultural or religious beliefs that support self-preservation.
But the best one is so simple.
It is. The most universal, powerful protective factor is simply family and community support. Pure connectedness. Being willing to just sit and listen to someone's pain without judgment directly combats that deadly feeling of thwarted belongingness we talked about.
Just showing up and validating their experience is a major step. It is the exact opposite of the stigma that keeps people suffering in the dark.
This raises an important question, and it is something I want to leave you with to ponder today.
Let's hear it.
It builds right on Thomas Joiner's theory of acquired capability. We learned today that humans can unconsciously acquire the capability for extreme self-harm through repeated exposure to pain, violence, and chronic trauma.
Building that psychic callus.
Right. But if capability can be acquired in a negative direction, could we reverse engineer that concept as a society?
What do you mean?
Could we proactively design our schools, our corporate workplaces, and our local communities to help individuals deliberately build an acquired capability for radical resilience, emotional articulation, and profound social connection long before the emotional pain ever begins?
Wow. That is a powerful thought to carry with you and a goal worth working toward. Thank you for joining us on this deep dive. Stay curious, look out for each other, and we will catch you next time.